Welcome, everyone. We're really glad you joined us today for this wonderful, exciting webinar. My name is Natalie King. I'm the Director of Training for AccuFocus. We have two great speakers today that are going to help guide you through our topic on addressing corneal wound healing. You'll love what they have to share with you. They have a lot of great pearls and a lot of experience. But before we go any further, I just want to cover a few housekeeping items. So one, I want to let you know the call is recorded, and it will be available to you shortly after this call. And for those that are unable to join us today, they will be available for them as well. So we'll send you the link to view it within the week or so. Before I introduce our speakers, I just want to advise you that the comments of our guest speakers on this webinar are not necessarily those of AccuFocus Incorporated. But let me introduce our speakers. Dr. Eric Brooker is the Medical Director of Advanced Vision Institute in Las Vegas, Nevada. He's a published author, an accomplished speaker. He is also a consultant for AccuFocus, where he helps to train camera surgeons worldwide. And Dr. Steve Schallhorn is in private practice in San Diego, California. Other than being a pioneer in ophthalmology, he's a professor of ophthalmology in the University of California School System. He's the Chief Medical Officer for Zeiss and also a medical advisor and surgical trainer for us at AccuFocus. So we're excited to have them with us today to share their post-op management tips. So thank you, Steve and Eric, for joining us today. And Steve, if you want to get us started, we're ready to go.
Thanks, Natalie. Hey, welcome everybody too on the call. I think you're going to get a lot out of this program. I'm very impressed with the material that's in here. But first, before we get started, I want to give you some perspective. We can talk about wound healing responses and issues and how to manage them. We will in great detail, but the perspective. Listen, the vast majority of patients have good outcomes. There were only 5% of patients in the clinical trial that had a wound healing response that was accompanied by a hyperopic shift, and Eric's going to talk to you more about that. So perspective. We're talking about at most 5% of patients, because even if a patient has a hyperopic shift, and I've seen patients with a hyperopic shift, that doesn't mean they're unhappy. That doesn't mean they're not satisfied. But it is an indication of a wound healing response. So what we're going to talk about, how to identify and best manage and treat those patients. Next slide. So even before we get started, though, it's important that patients understand that patients are told in a discussion beforehand about the wound healing response. That a small percentage of patients, they can have a response that is more aggressive, that may require additional treatment, eye drops. It's possible that a patient may have that, and a more aggressive healing response. And we can't identify right now which of those patients can have that. I'm going to turn it over to Eric now.
Okay, great. Steve, thank you so much. And first, I just want to welcome everyone to the call, and thank you for being here. But I also want to congratulate you for being involved at the forefront of the ophthalmic industry. This is a new segment in the industry of ophthalmology, the presbyopia, and managing corneal wound healing within the cornea. There's a lot of new things that we can learn about managing these patients, just as we did when we first started managing patients for LASIK and other refractive procedures. So as we evolve and we learn more, we're going to try to give you the best practices to implement in your clinic in order to optimize your outcome and get the best results. So let's go ahead and get started. Today I'm going to be talking to you about managing these patients for corneal wound healing. So as Steve gave a great overview, it's a natural and intricate process, wound healing of the cornea, and there's many factors that can influence both the speed and efficacy of a corneal wound healing response. So in order to minimize this, we have to take a look at a few different factors. The first is a surgical procedure, and we're going to talk about how to optimize your surgical procedure to decrease the amount of wound healing response experienced by your patients. We want to decrease inflammation The less inflammation, less risk of a wound healing response, the less edema, the better. The better nutrient flow through the corneal inlays is going to be also very helpful. Types of post-op medication, the therapeutic regimen is also crucial. And if you're going to be putting something in the cornea, it's important that you have a foreign body that's in the cornea, whether it's an inlay or something different, that the body's not going to respond to. And so these inlays that are being developed and put in the cornea have all been tested thoroughly, and those tests have been submitted to the FDA to demonstrate that these are materials that the body can easily tolerate within the tissue of the cornea. Now, as Steve mentioned, all the corneal procedures, including inlays, can have some type of wound healing response. And on the right of this slide, you can see an eyelid flipped up there. That's one of my patients that's having a giant papillary conjunctivitis. And this is in response to a contact lens overwear. And the body starts coating the contact lens with protein and starts having a response to it. The slide below is a patient that had a small fiber underneath their contact, and the corneal epithelium started to coat over that fiber, and actually was then underneath the epithelium. So I had to remove some epithelium to slide that piece of fiber out. And why I put these up there is just to demonstrate that the body's natural effect is to respond to anything that it recognizes as foreign within the body. But once it's okay with it, it just starts to tolerate it. And that works really well. So as far as an aggressive wound healing response, and that's what we're going to focus on later in this talk, only a small percentage of patients have an aggressive response to a refractive procedure. And if you maximize and optimize your procedures and your post-op regimen, it could be as low as 3% or even lower. But when you don't, it could increase and be a little bit higher. Okay, let's go to the next slide. So some factors that contribute to a wound healing response are individual genetics. Some people have more active immune systems than others. You can remember back with patients that we're having or we were designating as candidates for a PRK procedure, we'd be very careful of patients that had hyperactive immune system. And so we have to be careful with those type of patients also with these procedures as well. Now that we're using femtosecond lasers, they're a great thing, and that's what's enabled inlays to become very successful. But having those settings on the femtosecond laser are crucial so that you don't have a strong wound healing response and stimulate any type of inflammation within the cornea post-op. Again, surgical technique is very important, and we're going to touch on that, but the more you minimize manipulation within the cornea, the less the cornea is going to respond. So this is also crucial. Your post-op steroid therapy, also very important. This one's important because we need to stop the body from having a response to what we've introduced to the cornea and also to the trauma that was experienced during the surgical procedure. If patients have an atopic history, which means they're very allergic or hyperallergenic, then we need to probably treat that preoperatively, and that could be a mild steroid pre-op or maybe something like a mast cell stabilizer. Especially during an allergy season, I do that for my patients. And dry eyes is another very big one. We all know that dry eyes can involve inflammation, and we don't want inflammation within the cornea. So it's crucial that you're treating dry eyes aggressively post-operatively and even pre-operatively. In fact, if your patients have some form of dry eyes or inflammation, they shouldn't be going in for a refractive procedure, whether that's inlays or refractive surgery. Let's go on to the next slide. So when we talk about the surgical procedures, there is some recommendations as we've found from doing a number of these procedures. And AcuFocus is very diligent in the fact that they do analyze all of the data from the clinics worldwide and try to draw conclusions about what are the best techniques in order to maximize your outcomes. So the first thing we want to do is minimize surgical trauma. And that's, as I said earlier, that means less manipulation, less in and out of the pocket when you're doing this procedure, not getting too much fluid or irrigation that's causing swelling within the cornea. We've also found that going deeper within the stroma has less risk of acting the corneal keratocytes because we're deeper, further away from the epithelium. When you're using these femtosecond lasers, it's also crucial that you create a very smooth bed. So we want an easy dissection for the surgeon And also we need a smooth bread so that we're not getting activated keratocytes trying to fix things that are happening. Also, if you have a lot of tags during your dissection, that can create more inflammation and stimulate more of a wound healing response, so it increases your risk. Another thing we don't want to do is have our energies too high in the femtosecond laser so that we're causing damage at the side cut area, because this can damage epithelial cells or cause an epithelial abrasion, which again can activate this inflammatory response and create a late post-op wound healing response. So it's important when you're doing the procedure also to keep the eye hydrated. As the eye is dehydrating, we can get more SPK, more swelling, more inflammation. So these are just a few really good tips as far as things we can do surgically. So let's go to the next slide. So, as we mentioned earlier, when you have a foreign body in the cornea, the body's natural response is to try to encapsulate it in someone that's having a wound healing response. In a patient that's having an aggressive wound healing response, some things that can occur are nebulous haze formation. You can get stromal thickening over the inlay, even changes to the corneal curvature, which can then result in refractive changes. Now, this becomes even more of a concern for an inlay that's directly over the visual axis, and there's a couple of those present, and that could actually lead to loss of contrast sensitivity and also decrease in best-corrected vision. And that's one of the reasons I've always really liked the camera inlay, is that the center part or optics of the eye and the visual axis do not have any inlay in place, so there's less risk of there being any central haze or changes to this area of the cornea topographically.
Yeah, Eric, I think that's a really good point.
Yep.
I think that's a really good point. It's not in the central visual axis.
Yeah, and you can really see that here, Steve, in this OCT, how the center of the cornea is preserved, and that really preserves the natural optics of the eye as well. Right. So as you can see, if you see in this particular slide, to the left and right, that's the location of the inlay. And you can see it's very calm and quiet. Now I want you to remember what that looks like, because in this OCT, this shows no activation above the inlay whatsoever. It's a nice quiet cornea. Let's go to the next slide.
And it's in a good depth too.
Huh?
I was to say the depth is good.
Yeah, excellent depth. It's about exactly where it should be there. Okay, on this particular slide, again, we're looking at a normal wound healing response. And in this particular one, you can see on the left, a nice quiet corneal inlay. There's no haze around the edges. When you look on retroreflection through the center of the cornea, you don't see much swelling or anything there. All of your holes, the 8,400 microperforations that allow for the flow of nutrients through the cornea are all open. And to the right, you can see a pretty normal central topography. Now, you do see a little presence of a ring there over the corneal inlay, and you may see this on some patients, and that's completely normal to see that. Next slide. On this slide, you see what's called an aggressive wound healing response, and you can see on the OCT, and it's nicely magnified for us here, but you can see a lot of noise and activation over the inlay, and that creates what we call some steepening over the area of the inlay with some central flattening. And this can actually have an effect on the patient's refraction, and it would result in more of a shift toward a hyperopic range. So you got to remember where the patient started, and when you're monitoring these patients post-operatively, if you see them start to shift in a hyperopic direction, especially over 1 diopter, you can probably bet they may be having some type of wound healing response, and it may be an aggressive one, so we want to catch it early. Let's go to the next slide. So down in Australia early on, AccuFocus launched outside the U.S. originally, which is a very nice thing, so a lot of us can learn from what went on outside the U.S. And this was some cases done in Australia, and this particular site went ahead and removed some of the inlays and did analysis on these patients that were having these wound healing responses. And what they found is these particular patients were having macrophage accumulation along the inlay, which was resulting in that steepening on the topographies that you saw. And that's what happens. The body's trying to encapsulate what it recognizes as a foreign body. Now, this doesn't happen in all patients, But in the patients where it does happen, this is what's going on. Next slide. Let's just click through this one. So you can see this is magnified of something that we looked at earlier, but this is an aggressive wound healing response. And you can see the accumulation of the macrophages on the top of the inlay, resulting in that peripheral steepening and then the resultant central flattening. You go ahead and click on that slide again there. You can see that. And that can result in our hyperopic shift, as you may have heard. Next slide. So when we look at a patient that's having more of an aggressive wound healing response, you can see at the top is the first slide we looked at, which is a mild wound healing response. This is normal. As you start to get into a more moderate one, you can start to see this more of an orange steepening circular around the cornea. And as you get toward the bottom two, you can see more of an aggressive wound healing response where you get a lot of steepening. And that could be a difference between 6 to 1, 6 diopters of steepening over the inlay, and maybe just 1 compared to a 1 diopter centrally. So that the resultant flattening can result in that hyperopic shift. Now you can also see a little bit of this nebulous haze formation over the surface of the camera inlay here in the bottom right. And that's, if you start to see these signs, that means you're definitely having an aggressive wound healing response, and we need to implement some therapeutic management, which we're going to go over next. Next slide. So this brings me to assessing a wound healing response. So what we need to know is, do we have a mild wound healing response, a moderate wound healing response, or an aggressive wound healing response? So these are some key tools that you can use in the clinic in order to evaluate the cornea and see how aggressive this wound healing response is. So the first, you look on slit lamp, and is there haze present, or is there swelling in the corneal pocket? Is there any of these things present? You want to answer that. Topography, is there steepening over the inlay or flattening centrally? And you got to be careful on which topography you're using, because the scanning topographies like the orb scan or the Pentacam actually error out quite a bit when there's an inlay in place, and they haven't developed softwares yet in order to recognize that an inlay is in place. So they can a lot of times misrepresent the backside of the cornea in the best fit curve, which can result in some artifacts. So you want to, if you have a placido disc topography, those work the best as far as evaluating these things for a wound healing response. OCT, if you see it on topography, you want to take them to the OCT. You want to see what's going on over the inlay. Is there noise? Is there activation? Are there epithelial changes that are occurring in the form of a thickening centrally or over the inlay as well?
Yeah, and I would add,
go ahead.
Eric, I would sorry for interrupting. I would just add that if you have a high quality OCT, that if you have an aggressive wound healing response, you can see the epithelial thinning over the inlay itself from that. So it's another indication if you have one of these high quality OCTs.
Yeah, and there's a few of those that can do that, right, Steve? Now.
Yeah.
That's great. So, and another thing that usually these patients are going to have some type of subjective complaint, because if they're experiencing this, they're going to have a loss of their near vision first, usually. So if you have an inlay and they start to have a hyperopic shift, they're going to have some loss of near vision. If it's a very aggressive response, they may even have a little bit of decrease in their distance vision. So you want to really push these patients to understand how they're doing subjectively post-operatively. And that should correlate with their visual acuity. So if there's a reduction in their uncorrected visual acuity as well, when you look at their near and distance acuity, and that matches up with the subjective, then those are another couple of signs you want to look at. And again, that should also match up with your refraction.
Yes, and I would also say, what I found is that the patient presents typically by saying, my vision's not as good as it was, and that's almost always their near vision.
Exactly.
And so that's the presentation. So when you're thinking about that, you should be thinking about some kind of wound healing response on that presentation.
But the other thing you can look at is the OSI. Is the OSI elevated above expected levels? The AccuTarget HD is a wonderful instrument for monitoring patients post-operatively that have inlays. And this tells you the amount of forward light scatter. So if it's outside of normal post-operatively and it's very elevated and you're seeing some of these other correlated changes, again, this could correlate with some inflammation, even if it's hard to recognize at this level that could be going on for this particular patient. The other thing that you can pull off your AccuTarget HD is it does do an objective refraction. And I would invite you to utilize that objective refractive number when you're starting your normal refractions on these patients. When you're doing an autorefractor on a patient that has a camera inlay in place, it's completely inaccurate. There's no autorefractors that can work well to give you a starting point postoperatively because it doesn't recognize the inlay. The AccuTarget HD, however, does do an objective refraction, and I find oftentimes as long as the tear film's not completely abnormal, will actually give you a very good starting point on these patients. Next slide. Okay, so we've talked about some ways to prevent wound healing response and minimize wound healing response. We've looked at what an aggressive wound healing response looks like. Now let's talk about how to manage these patients. Well, the first one is we talked about is dry eyes, aggressive dry eye treatment. This means non-preserved tears. In my office, we use the Oasis tears. We also put punctal plugs in all of these patients. And we just put inferior plugs, but we do put a silicone plug. We don't really mess with the 3-month plug. We like to make sure they stay in place because some wound healing responses can happen late if the patients get dry after 3 months. And we find it's just better to start and maximize the tear foam and optimize the tear foam ahead of time to allow these patients the optimal environment to recover postoperatively. We also do aggressive meibomian therapies. If patients have blepharitis pre-op, we take care of that. We do the BlephX treatment. We also do a MiboFlow treatment if they need it, and just make sure that we've optimized their tear film so they can heal. The next step we look at is aggressive postoperative steroids, and we like to go with an aggressive steroid early, and we prescribe in high dose early with a nice slow taper in order that we don't get one of these wound healing responses. And we've also found that the immunomodulators like cyclosporin are very effective in stopping these late onset wound healing responses. And we've gotten great results using that. So I'd recommend that as well. Next slide. And I just wanted to put this slide up, and you can all probably remember this back when you were going through school. This is some studies done by Libowitz and Cooperman that just looked at how much does dosage affect the amount of inflammation within the cornea. When you do a drop every 4 hours, that totals about 6 doses, and that only brings down corneal inflammation around 11%. But when you go every 2 hours, that equates to about 10 doses, and we're talking about a 30% reduction. And then 1 drop every hour, that's 18 doses, which brings it down to about 51%. And I wanted to put this slide up just to remind everybody that the dosage with steroids, the more aggressive you are, the faster you decrease inflammation early, which can affect the late onset healing response in these particular patients. Next slide. So in our office, we use this particular regimen, which is a little bit different than the MAB recommended one. We started with the MAB recommended regimen, but we found a little bit better success with this regimen in our particular office. We do prednisolone acetate every hour for the day 1 through 3. And part of the reason we went to that is we found patients, when we put them on 4 times a day, they just weren't getting them in 4 times a day. And that was not decreasing inflammation enough for our liking. So day 4 through 7, we bring them down to Q3H. And then the 2nd through the 4th week, we switch over to a milder steroid in order to decrease the risk of them having an IOP spike or any other complications that can come with a stronger steroid. So we go to 4 times a day on the FML. And then the 2nd month, we continue the taper in the 3rd month as well.
Eric, this looks,
yep.
If this looks surprisingly like the kind of dose you would use in a PRK patient who has an aggressive healing response, it is. It's very similar because you're talking about a similar type of response. Right. And so think of this like an aggressive wound healing response after PRK. A heavy steroid at first and then a slow taper.
Exactly. Yep. That's great. And I think adding a cyclosporin back in around 4 weeks, a lot of doctors, including myself, have found this very effective. Some people are even compounding it now because it's so cheap to compound it and giving that to their patients. And I just want to put this small reminder down at the bottom is that you do have to monitor your patients closely for IOP spikes, especially if you're using different steroids like a Durezol or a dexamethasone. Dexamethasone has a much higher risk of increase in the IOP. In these patients, inlay patients, if you get an IOP spike, it is going to cause corneal swelling. That corneal swelling is going to lead to forward light scatter. And that forward light scatter is going to decrease the patient's contrast and also drop their visual acuity, which is going to make for an unhappy patient. So if you do get an IOP spike, you need to get it down as quickly as possible on these patients. Anything else from you, Steve, on this slide?
No, I think the steroid taper is really one of the hallmark treatments for this. And as Eric mentioned, especially in the population of patients we're going to be treating, monitor the IOP. Monitor the IOP in these patients.
Actually, that's great. All right, let's go next slide. So, when you're grading your corneal wound healing response, how do you want to manage these patients? Well, if you have a mild wound healing response, which is a prescription change that you found on your refraction that's equal to 0.5 diopters or less than 1 diopter, so 0.75 to 0.5, we would call this a minimal possible hyperopic type shift, maybe a possible early wound healing response, and we would start with the ocular surface management. That means aggressive management, though. That means plugs. If it's omega-3s, your cyclosporin, you want to implement all of those things, and they can stay on their current steroid regimen if they're on one. If they're not, you want to be watching them very carefully. If they have more of a moderate wound healing response, which means that they have more signs and symptoms, plus a prescription change that's a little bit higher than 0.75, then we want to go ahead and put them on the same ocular surface management, but we're going to reinstate that steroid regimen and try to start getting things reversed. And that would be just starting again with, in our office we'd go every hour, but at minimum you want to start with the Pred Forte 4 times a day. And then again, taper them off. And hopefully in most patients that's gonna stop this process and reverse everything. And the same thing applies for a severe wound healing response. You're going to do the exact same thing. So moderate and severe, that's what you're going to do. If it's mild and they don't have a lot of signs or symptoms, then you could just start with ocular surface management. Okay, let's go next slide. One back. Let's see. Okay, right there. So once you're treating that shift, what's going to happen? Well, first thing we ask, is it resolved? And if it is resolved, that's great. Then you can just follow the patients closely for stability. And that's going to be for patients that have an aggressive wound healing response. 85% or more of those patients are going to respond to these therapies. Okay. If you treated the patients and they didn't respond as well, but they don't have any symptoms, you can continue to follow them, but I would follow them very closely. If it hasn't resolved and they have symptoms, you need to start considering possible early removal on these patients because we don't want the wound healing response to get worse or it's starting to possibly affect the patient's best corrected vision. These are ones you want to consider an early removal. And that applies also to patients that you've treated with the steroid regimen, you've treated their dry eyes, but they keep rebounding. Those patients, there's a chance that they're not going to get better, and they're probably unhappy at that point, so it's better to get an early removal on these patients. And the nice thing that AccuFocus found in the FDA study is when you remove the inlay, the things just go back to normal, and patients recover well. They don't have a decrease in best corrected visual acuity. And you could always go back and treat them with a different procedure if needed in the future. But the worst thing you could do in a patient that's rebounding and their hyperopia is not stable is try to treat them again with a laser because that's going to activate more keratocytes, more wound healing, and you can put yourself at a higher risk for a more complex case with those patients. Next slide. So, let's kind of start to sum things up here. The first step in the wound healing response decision tree is to evaluate the patient's symptoms and look at some of the following tests, like their subjective response. Are the patients having subjective symptoms, loss of near vision, loss of distance vision, and is that correlating with their visual acuity? Is their refraction shifting, and how much is it shifting? Next slide. And then as you evaluate them on the slit lamp, you want to look for any haze formation. And then also looking back at your topography to see if there's any steepening over the inlay or central flattening. Also, I'd want to pull in an OCT to look for any noise above the inlay or epithelial changes if you have the ability to look at that. And is there an increase in noise, as we talked about, over the inlay? Next slide. So if you do have patients that are experiencing some of these abnormal or healing responses, AcuFocus has a wide array of support for you, including people like myself and Dr. Schauhorn and a clinical specialist across the U.S. So please let the clinical support team know so they can help you in managing these patients until you feel comfortable. Next slide. And I guess this is just another review slide that we'll just touch on. If you initially treat these patients and they're not responding or they're continuing to get worse and things are continuing to change, it's better to remove them early. In these patients where you do remove it, they should return back to baseline. And post-removal, you just want to do, once you take it out, you want to put them on an antibiotic and a steroid 4 times a day or so until things settle down. And as you see at the bottom here, approximately 5% of those that have a wound healing response will not rebound, even in surgeons' early cases. Next slide. So we're just going to sum everything up here. Again, going all the way back to the start, all corneal procedures, including inlays, implants, anything like that, can have some form of a wound healing response. In order to prevent these type of wound healing responses, we want to optimize the surgical technique, manage dry eyes pre and post-operatively, prescribe effective steroids early at high doses with a slow taper. You want to utilize your immunomodulators like cyclosporin and follow the therapeutic management recommendations if a wound healing response occurs. And if it's not responsive to that therapeutic management, in these aggressive wound thinning responses, you want to remove the inlay early. Next slide. So I'm going to pass it now back over to Dr. Schauhorn here, and I want to thank you all for your attention.
Hey, thanks, Eric. That's a great overview of all the issues that deal with managing this. And again, back to the 40,000-foot view. The majority of patients are happy. What we're talking about are patients that really present, and typically they present with an issue. Typically that's related to vision, and most typically that's related to their near vision. They had it. It was better a while ago. Now it's not as good, and that's the typical case. And of course, managing the unhappy patient is a little bit different than what we're talking about, because what we're talking about here is the wound healing response. One of the elements of that, the wound healing response, again, in a small percentage of patients, they can have a more aggressive wound healing response. And if you properly identify those patients and get them treated, the majority of them can be corrected and back to being happy again. But again, the 40,000-foot view, this is, I guess, for lack of a better word, graduate level understanding of how to get the optimal outcomes for the camera, even in those patients, even those small set of patients who have a more aggressive wound healing response. And Eric, it was a great summary of that whole process of identifying and treating them, and the etiology, et cetera. So listen, I also want to thank you for being on the call. I'm going to turn it back over to Natalie, and we're very interested and anxious to hear your questions at this point. So over to you, Natalie.
Thank you very much. Great job, Steve and Eric. Really appreciate it. I just wanted to make sure that everyone knew where to find some of the clinical references that can help you manage some of these responses. So really the first step, as Eric and Steve described, is using the wound healing, what we call decision tree, and Eric broke it down into a slide that was very easily seen, but we have what we call our Medical Advisory Board guidelines, and in the Clinical Pearls booklets, we have one that's an OD Clinical Pearls and an MD Clinical Pearls, and both of those, at the very back of that booklet, is the wound healing response management decision tree. So if you start at the very beginning and work your way through that, it helps you to better identify those patients and how to treat those patients. It helps you, to provide a grade and that type of thing. So if you don't have that, please ask your AccuFocus support team, and they can walk you through that. They can actually get you some of those as well. So thank you very much again, Steve and Eric. I have put their contact information up on the screen for all of you if you'd like to contact them further with any other questions. But now we want to get to some of your great questions that you sent in during the webinar, so thanks very, very much. We've got a few minutes here as time allows, so if you think of anything while we're asking these additional questions, please send some in and we'll try and fit you all in to this. So this one, Eric, I'm going to punt this first question to you. This question is, what is the typical patient recovery once they've been on a second round of steroids?
Yeah, on the second round of steroids, you're usually going to see a response within the first couple of weeks. And especially if you have them on also an immunomodulator, like a cyclosporin, usually they're going to start to experience some improvement in the first couple of weeks.
Great, thanks. What would you expect the OSI post-surgery to be? And not just for these patients, but this is, a little bit off the corneal wound healing. But
it's a little off the camera, but it's a good question. So the OSI score is going to be absolutely going to be high post-operatively, depending on how much surgical manipulation, how much swelling the patient has. In a good surgery where there's not a lot of swelling and not a lot of manipulation in the proper laser settings, it's probably going to range around 1 week at about a 4, a little over a 4 or so. When you start to get it between 1 and 3 months, it should be getting closer to around a 2.5 or so. And when you get to 3 months, hopefully we want it to be less than 2.4. And generally, once they get below about a 2.4, the patients start to be pretty happy with their visual quality of vision.
Great, thanks. Another question came in from one of the participants. They want to know, they don't use Pred Forte. They say they use Durezol, and they want to know if that's okay.
Well, I was just going to say, yes, that's okay. Obviously, what we're talking about is, as Eric said, is suppressing the inflammatory response, and Durezol can certainly do that. The key really here is to put them on a high dose to suppression dose, and then really monitor their follow-up and monitor how they're doing with it, and adjusting if you need to adjust based on their response. Some patients are going to respond quickly. Some are not going to respond as quickly. And again, this is where you're going to have to manage and follow the patients. You got to manage them anyways. You're putting them on a high dose steroid like that for IOP anyways. So the answer is yes, it could work. Durezol could definitely work.
Yeah, I agree with that. I agree with that. I think, again, you do have to watch the pressures on the Durezol. I think it may have a little bit higher risk of increasing the IOP, so be careful.
Here's a related question for you, Steve. One of the participants wants to know, they said, please explain why you use 1% Pred for 2 weeks instead of 4 weeks.
Okay, well, that's another good question as far as what to do with the steroid dosing. And the answer is, you know what, the the whole key to this is to identify it and get them on a high-dose steroid. Then modulate what you do or how long you put them on it based on their response. If they're having a good, healthy response, say at 1 week, you can start tapering. You can start adjusting your regimen of the high-dose steroid. So I like 2 weeks. I don't like the 4 weeks on that high dose of the Pred Forte. But it's all going to depend on how you want to modulate that response. The second thing is that, for as important as that is to modulate it, it's really important to have them on a long taper. And getting them off some Pred Forte or Durezol, it's going to have a higher propensity for raising IOP. Getting them off of like a fluoromethalone for the longer-term taper over several months. And by the way, it's been my experience that patients that have this more aggressive wound healing response are typically the patients that are really not compliant with their original steroid course, which is a longer course of steroids. And so if they're not going to be compliant, if compliance was an issue with their original post-operative course, you're going to have to really talk to the patient about being compliant now that they've got this healing response. So again, the early aggressive and then monitor how well it goes, and then the longer-term taper is really one of the keys to getting this aggressive wound healing response under control.
One more question right now I see is, if a patient is a steroid responder, would that be a contraindication for the camera inlay? And how would you try and anticipate if a patient is a steroid responder prior to the camera inlay procedure? I don't know which one of you might want to take that.
Well, I would go ahead, Eric, and then I'll chime in.
Okay. I was going to say, if you know someone's a steroid responder ahead of time, and they don't have glaucoma, they possibly could be a candidate, but you'd want to be, aware of that and make notation, and definitely try to get them on a milder steroid early, and really make sure you manage all their dry eyes and inflammation early, and be ready to start them on something to reduce IOP in that case. And I've seen patients that have had IOP responses that were managed quickly, and as they were tapered off, everything turned out fine. It wasn't an issue. It's the ones where the patients aren't being followed up more frequently enough, and they're having these IOP spikes, and no one knows about it for a month. That's where we run into issues.
And I would add that if the patient's got a known steroid response, it would be very cautious. I'd be very cautious of that patient in the camera. Do they have the status of their optic, a very individual basis, status of their optic nerve, their age, what kind of response did they have? Why were they on steroids? Why do you know they have the response? A lot of factors come into play. Certainly if there's any optic nerve issues that they've already got, I wouldn't, because you're going to have them on steroids in the normal post-operative regime. But I think there are patients that have had a steroid response. Perhaps they had some issue. Again, the reason they were put on steroids in the first place. To know they have a steroid response would be important to add up. But I would say proceed with caution with those cases.
Well, thank you very much. It looks like that's all our questions. So Eric and Steve, either one of you have any last-minute key takeaways before we wrap things up here?
Well, a couple things. One is, hey, listen, thanks everybody for being on the call. Again, this is really very graduate level degree of understanding the camera and how to manage those few patients who may have an aggressive wound healing response. And just the fact that you're on the call, kind of elevates you to that level of wanting to understand that and how to manage it. I think the important thing is it happens rarely. When it does, you need to recognize it, and there's some important diagnostic tests that come into play. And then we've talked quite a bit, and Eric really went over very well how to manage those patients. And most patients that fall in that category can be appropriately managed, and the patients can return to to their happy state, for lack of a better word.
Thank you, Steve.
I would just add, and again, thank you all for attending. We really appreciate it. But also wanted to say, don't be afraid of these patients. These are easy things to manage. In the worst case scenario, one of the things that I love about inlays is that they are removable, and it's a very small percentage that need to be removed. But when they need to be removed, it's not a very difficult procedure to remove an inlay, and patients recover well. So, and it's just helping those patients understand ahead of time. And I counsel my patients that everyone heals differently, and I do the same thing with my LASIK patients. I say everyone heals differently. Some people heal normally, some people don't heal aggressively at all, and some people heal real aggressively. And if post-operatively, if you're someone that heals more aggressively, we may modulate your medications that you're going to be on. Just depends on how you're doing. And I talk to them the same way post-operatively. I let them know that if they're healing aggressively, that they need to be better about their eye drops. We're going to add some other therapies, and that they're an aggressive wound healer, or aggressive healer. Or people that are normal, I let them know you're a fast healer, you're a great healer, and you're recovering great. And that's what we're really dealing with, is the patient's individual body and how their body heals. And we're just trying to make it and optimize that so they get the best outcome. So thanks again for being on the call.
Great. Thank you very much, Eric and Steve. That was fantastic. And I hope that you've all found it really valuable. Just wanted to let you know our next clinical webinar won't be until February. We'll be sending out the schedule in the next few weeks of what topics will be involved in that. So stay tuned as well for the next announcement. We will also provide you the link for today's webinar. So everyone, I hope you have a wonderful day. Thanks again for joining. Happy holidays.